Good morning and welcome to another podcast from Odell Technology. Today we're fortunate enough to be joined by David Fitzgerald, who is the Director of Specialist Medicine at Barts Healthcare. Hello, David.
Hi, Stephen.
How are you?
I'm good, thank you.
All right, David. Well, welcome to the podcast. What I'd like to do, first of all, is to ask you to introduce yourself to the audience by telling us about your professional background and then tell us exactly what you're doing up to this point in time.
Okay, thanks very much. So I graduated from Cardiff University with a degree in neurosciences. At that time, I decided that I didn't want to go into academia, which is probably the most likely route. And I found myself applying for a role within the NHS. And at that time, it was a nuclear medicine technologist role, so a field of medical imaging, using radioactive materials in order to be able to image disease processes within the body. I had absolutely no idea what that meant at the time, and like most people, the best way to get a job, my mum found it in a local newspaper, so I'm showing my age a little bit there. So applied for the role and was successful at interview. So I started my career in the NHS in the early 2000s in a hospital called Medway Maritime Hospital in Gillingham in Kent. And I then spent about 10 years working in a number of different hospitals in nuclear medicine and moving through the kind of professional ranks, but then also progressing from a kind of leadership and managerial point of view. Around about 10 years later, I made the move into general management, and I moved to another NHS organisation and took on a role as general manager for cancer services. And from there, I've undertaken a number of academic development opportunities around leadership and management, and now find myself as the divisional director of operations for specialist medicine for the Royal London Hospital, which is a part of the Barts Health NHS Trust, which is a group of hospitals in East London.
Fantastic. So could you describe the position and how and what the position entails on a daily, weekly, monthly basis?
Sure. So in essence, my role is really about, I think there's a number of different facets to it. The main things really traditionally are kind of finance and performance management. So ensuring that we meet the statutory targets that are set for the NHS in terms of access and time to treatment. I'm responsible for the financial delivery of the division, so ensuring that we deliver within our budgets. And then from that is around development of business cases in order to obtain investment to deliver our services in an improved way for obviously the benefits of the patients that we serve. I think sort of a less formal way of describing my role is that I see myself as the link between the kind of corporate management and the clinical services. And I think that one of the benefits that I have, having had a clinical role prior to moving into a general management role, helps me to kind of translate some of the language between the clinical teams and the kind of governance side of things from a corporate perspective, so that we can explain why we want to do something from a clinical service point of view, but also can then translate that into language that the executive understands, so that we can get our business cases approved and investment achieved.
I see. And David, what sort of services are involved in your portfolio?
So the Royal London is an interesting hospital in that it has a huge proportion of specialised commissioning. So we have a very large amount of specialist services that happen within the hospital. So we are a major trauma centre for London and the south east of England. We also have quite a lot of specialised surgical and medical services, but we also provide general hospital services to the local borough population. So within my division, the hospital is carved up into 6 divisions. Mine is specialist medicine, and it is slightly unusual compared to other NHS hospitals in that as a medical division, I don't have the emergency department I don't have older people's services, and I don't have acute medicine. They sit in our emergency care and trauma division. So my division of specialist medicine is truly only the specialist services within medicine. So I have gastroenterology, rheumatology, dermatology, renal, and lots more ologies beside.
Okay, all right, fascinating. So tell me about some of the innovative work you've been doing over the last few years in your division.
So I think one of the things that really stands out, and I think for a number of different reasons, one, because of the route to funding, but two, to meet the needs of our population, which is, again, relatively unique even across the UK. So North East London, and in particular where the Royal London is based in the borough of Tower Hamlets, is one of the most diverse boroughs in the whole of the country. So I think there's something like over 180 languages that are spoken within the borough. We have a very high Bangladeshi population, but we have a huge range of other demographics. We also have a very young and transient population as well. So the average age within the borough of Tower Hamlets is relatively young, but we also have incredibly high deprivation. So one of the services that sits with me is renal, and for that we provide dialysis and tertiary renal services, so transplant and other renal replacement therapies across North East London. So they are managed out of the Royal London Hospital, but we actually have dialysis units across 6 hospitals, which some are part of the Barts Health group, others actually belong to other NHS trusts. So the particular project I was going to speak about is something that we're calling an independent therapy centre. So without wanting to teach people to suck eggs, for those that don't know a lot about renal replacement therapy, in essence, there are kind of 4 ways to deliver that. The one that most people potentially would be aware of would be in-centre hemodialysis. So a patient comes to the hospital, they get hooked up to a machine, that filters their blood for them. They sit there for about 4 hours, 3 times a week, and it essentially purifies their blood, keeps them nice and healthy, and away they go. The other option with that is to do home hemodialysis. So the patients can actually have the machine installed in their own home. Again, they would usually dialyse 3 times a week, but they're able to choose much more so when they do their dialysis. It's in their own home. They can do it overnight. They can do it at lunchtime. They can do it before they go to work, whichever they choose. Obviously, if they're in centre, they get given their slots and they have to attend 3 times a week at those times. They don't really have a choice. The third option is peritoneal dialysis. So again, patients can do this at home, and essentially they use their abdomen as a kidney. And they will use that, they put in some fluid, drain that off, and that acts to purify the blood that way. And the fourth would be a kidney transplant. So one of the areas that we're trying to drive an improvement in is that we know that patients have better outcomes and better experience of dialysis if they do their own dialysis at home. The problem that we have in North East London, again, related to the deprivation and the huge range of different social and cultural groups, is that we have a very high population that live in houses of multiple occupancy. A lot of people rent a property. A lot of people just don't have the physical space in which to be able to install the machinery that's needed to do home hemodialysis. So although we have patients that we could train and would be perfectly capable of undertaking their dialysis at home, they're not able to do that. So we're very fortunate that we have a charity that supports the trust called Barts Charity. We bid to them for just shy of £4 million to be able to undertake a construction project at Mile End Hospital, which is just up the road from the Royal London. It's a community hospital. And we're converting an old community ward into what we're calling the Independent Therapy Centre. So what that will enable us to do is to bring together the training centre for both home hemodialysis, training for peritoneal dialysis. We're also going to be creating a young adult centre. So at the moment, our 16 to 25-year-olds go into the general in-centre dialysis unit. So that may mean that they're alongside 70 and 80-year-olds that they have no connection with. It can be quite intimidating. It's not a very enjoyable experience for them. So we're going to create a brand new dedicated facility just for our 16 to 25-year-olds for hemodialysis. And the final thing is to provide what we're calling home away from home dialysis. So these will be dialysis stations that patients can treat as though they're in their home. So they can travel to the centre. We're going to try and demedicalise it as much as you possibly can. And patients will be able to choose as and when they go and do their dialysis. We'll have 5 stations, so 5 machines to be able to do that. But the other thing that we'll also have 3 bedrooms where patients can come and actually do nocturnal dialysis. So what they can do is they can come into the unit, they have a bedroom with an ensuite bathroom, and they will be able to stay in that overnight to be able to undertake their dialysis whilst they're asleep. And again, that provides much better patient outcomes because they dialyse over a longer period of time. It has less impact on them in terms of tiredness. And it means that if you're doing it overnight, it doesn't impact your day. So you can go to work, you can see your friends, you can socialise, you can do all those things that you're restricted when you have in-centre dialysis. So we're meeting the needs of not only the deprivation of our population, but also the health needs of our population in providing them with a dialysis modality that leads to better outcomes. And hopefully what that means is that we'll have a fitter and healthier dialysis population that will then be able to transplant and give them kidney transplants, which means that they can come off dialysis.
Absolutely fabulous. I had no idea. Tell me, are you measuring the outcomes of this activity?
Yeah, absolutely. So we'll do that in both a quantitative and a qualitative way. So looking at patient experience. So one of the things that is done very, very well across renal nationally is that there's patient-reported outcomes. So there's a survey essentially each year that goes out to all patients who are having hemodialysis. And at the moment, Barts Health scores pretty poorly in those metrics. So one of the things that obviously we hope to see from this is that we will significantly improve our patient experience by being able to provide this sort of a facility where they can undertake their own dialysis. Quantitatively, we'll be looking at the financial impact and the macro health economic impact. So we have a significant demand capacity mismatch at the moment, and that's only going to get worse in North East London. So the population growth predictions are quite frightening, and with that we expect that there will be a significant growth in the demand for dialysis as well. So what we're looking to do with this is to be able to provide facilities that are lower cost, both from a capital investment, so building and fitting out dialysis units is very expensive, and then obviously staffing them is very expensive. So if we can train patients and enable them to be responsible for their own care, we can obviously then reduce the staffing that we have available. And to go as far as with the independent therapy centre, the idea will be that the home away from home will have no staffing in it whatsoever. It'll be entirely patient run.
Tell me, with delivery of the dialysis, is that just done through a logistics company? How do people access their dialysis?
No, it's provided as a healthcare service. So we will do that as part of our service. So it's a hospital service in effect. There are examples of partnering with other companies. And so there are examples, and we have good relationships with the main providers of dialysis machinery and consumables. So the main partners that we work with at the moment are Fresenius, Baxter and Quanta. And as part of our ongoing work around transforming our dialysis care, and obviously because of the large amount of investment that we're going to need over the next 10 years or so to meet the demand, there is the potential for private finance to come in to look at partnering. There are examples across the country already where NHS trusts have partnered with private companies. The private company have built a dialysis unit, and there are two options then. Either the trust effectively rents that unit off of the private company and pays them rent in order to return on the investment, or the private company themselves may actually deliver the clinical care. So they may staff it, and then the NHS either the trust or the commissioners would then pay that private company for that dialysis activity, again to get that return on investment.
So a managed service, in other words.
Yes, yes.
Okay, and is that's not the case in your situation, is it?
No, not currently. So one of the things that we are doing is we're doing a full review of how we're going to meet the demand that we need to over the next 10 years or so. And one of the options within that, we will need to look to private companies potentially to be able to support us with that. To give you an idea, we're kind of in the realms of looking at needing to build probably 3 or 4 new dialysis units. From a capital cost alone, we're probably looking in the region of somewhere like 50 or 60 million pounds.
Yes. So you will need partnerships in the future.
Probably.
Yes. That's fair enough. I understand. Look, I'm very grateful for your time today, and I hope we can come back to you in the future about the other divisions and the other projects you're involved in. I know your time is sparse because of the demands upon you, but I'm very grateful for your time today, and I just like to thank you very much for sharing these fantastic projects that are going on in the National Health Service in the United Kingdom, and particularly in a very challenging time and a very challenging place. I'm very pleased you've got the clinical background you have, and I think that was an interesting comment about how you can actually relay information meaningfully to the executive management, which I think is interesting. Tell me, when you put a business plan together, do you get a team of people to do that with you?
It depends really. So it's probably in terms of the complexity and really what I mean by that is the total cost. So if we're talking about large value cases, then we're usually fortunate that we will get particular support to either write the business case or project management type support. The reality is that the majority of cases we have to develop ourselves. So I'm very lucky that I have 3 very capable general managers. So I rely on them quite heavily to be able to support to build those cases. And then what I would do is to review and support with kind of expanding and hopefully applying a bit of finesse that will get those through the approval process.
Okay, all right. Well, look, thank you again for your time today. I look forward to talking to you in the near future. And it's always a pleasure to talk to you.
Thank you. Thanks. It was lovely talking to you too.